advocates to collaborate on solutions to the growing mortality crisis facing American mothers and babies, especially those of color, who needlessly die during pregnancy, childbirth, and the postpartum period. My name is Congresswoman Robin Kelly, and I'm so proud to represent Illinois' 2nd Congressional District. In Congress, I serve on the House Energy and Commerce Committee, including the Health Subcommittee, and I'm the chair of the Congressional Black Caucus Health Brain Trust. So health care and health access are so important to me. I have been using my platform and the backing of the CBC to advocate for maternal health since my early days in Congress. Today, I want to discuss with our panelists the current state of the maternal mortality crisis and, most importantly, ways to improve maternal and infant health, especially during the COVID-19 crisis. I would like to take this opportunity to introduce our fabulous panel. We have Dr. Nicole Williams. Dr. Williams has an extensive research background and too many awards and accomplishments to list here. It would literally take the whole hour. Perhaps the biggest stamp of approval is that she's my doctor. She's a renowned gynecologic surgeon and an expert in women's health. She completed her undergraduate degree at the University of Illinois Urbana and medical school at Loyola University Stritch School of Medicine, where she was a National Institute of Health Research grantee. She is also active in the American College of Obstetrics and Gynecologists, and she has served as a junior fellow Illinois section chairperson and was appointed to a national position on the International Affairs Committee. She has also held positions as teaching, faculty, and clinical instructor with the University of Illinois at Chicago, as well as the Rush University and Medical Center. Our next panelist, Dr. Joia Crear-Perry, is the founder and president of the National Birth Equity Collaborative. Dr. Crear-Perry completed her medical degree at Louisiana State University and her residency in obstetrics and gynecology at Tulane University's School of Medicine. She was also recognized as a fellow of the American College of Obstetrics and Gynecology. Next, we have Yaya DaCosta, a talented actress starring in Chicago Med as Nurse April Sexton. I watch her all the time. She also is a Brown alumna who graduated with a degree in Africana Studies and International Relations. In her spare time, she is also a doula and maternal health advocate. Finally, Dr. Jennifer Villavicencio, who currently serves as the Darney Landy Fellow in the Strategies for Health Equity Department at ACOG. She received her bachelor's in neuroscience from the University of Miami and her medical education at the University of Central Florida. She completed her OBGYN residency at Brown University and Family Planning Fellowship at the University of Michigan. She also holds a master's in public policy from the Gerald R. Ford School of Public Policy at the University of Michigan. Thank you all so much for being here today. I am in awe of all of our panelists here today. I thought I was busy. I'll kick it off to Dr. Joia Crear-Perry to start the conversation. Thank you so much again.
As Congresswoman Kelly mentioned, I'm Dr. Joia Crear-Perry, the founder and president of the National Birth Equity Collaborative and a board member of the Black Mamas Matter Alliance. We are so honored, and I'm so honored to be here today with you to really talk about the fact that Black women are dying in childbirth still due to racism, classism, and gender oppression. And the Caucus on Black Women and Girls is coming together to come up with solutions like the Momnibus to ensure that that won't happen. We know with the death of the murder of Breonna Taylor in her sleep, so many Black women are undervalued. So it's our opportunity really to uplift and talk and make solutions to ensure that our children and our grandchildren don't have to live with the same unaccountability and non-accountability for being devalued in policy and in culture when it comes to our Black birthing bodies. So thank you again for participating for this important conversation. And we look forward to building a future where we all can thrive.
Do you have time for one question? I know you have to scoot. You recently worked with the United Nations Office of the High Commissioner for Human Rights to urge a human rights framework to improve maternal mortality. Can you talk to us a little bit about that experience and that framework and why it's so important, even in the United States?
Well, we understand the importance of having a human rights framework because in the United States, we know that Black people, women, the LGBTQ community has been fighting to get civil rights. The countries that have better maternal health outcomes than we do in the United States have embraced a human rights framework. And what that means is they believe all people have the ability to thrive just by virtue of being born. So unfortunately, in the United States, we believe people can earn the ability to thrive if they beg for rights through laws and policies. So you do things like not have access to childcare, not have access to healthcare for all, not have access to unemployment benefits, like especially this time during the COVID, when we tie our healthcare insurance to our employment. If you have a human rights framework, you would never say you only deserve healthcare coverage if your job gives it to you, right? It would be provided for you because we believe everybody should be able to thrive. So although as an OBGYN, it's important for us to undo the biases and the racism that's inside of healthcare, we as a nation have to commit that we believe that all people have the ability to thrive. And that means we have to believe that health is a right, and we commit to ensuring that all people have access to health.
I love that. Thank you so much again. I really appreciate you taking the time. I see Dr. Nicole Williams has joined us. Welcome, Dr. Williams. Really appreciate you being here. I'm gonna let you breathe a little bit, and I'm going to go to Yaya DaCosta to give her opening statement.
Thank you so much for having me here. This is a conversation that I've had in my communities and kind of on a grassroots level for a couple of years, and it's really wonderful to feel welcomed by you all, and it's great that the voice of the doula is being included in the conversation. Traditionally, a doula is someone that is there to support the birthing woman, the birthing person, and it's been seen, I think, in the Black community as a luxury. And so as the statistics are being revealed, as articles are being written, I'm noticing pregnant Black women becoming really fearful. Well, what's going to happen to me? Because now our awareness is expanding that these problems have been going on for a very long time, that they're systemic, that honestly, that they're an extension of the, experiments that were done on Black bodies since the beginning of medicine in this country, and so what we're experiencing today is the residue of that, and doula-ship is moving from a luxury to a necessity. So technically our job is to help her deal with pain, coping mechanisms, and a lot of times a woman, depending on the practice that she's seeing, attending, she might see various different midwives, she might see various different doctors, depending who's on that shift. And so the doula is the person who is consistent throughout her care. She's the person who has a little bit more time on her hands to prepare her mind, body, and spirit for this experience of birth. She's also kind of the link between the clinical aspects of birth and the more intangible, even spiritual, depending on the experience that we're having. So in a home birth setting, all of our efforts are on pain coping mechanisms and, just making the environment nice for her, making sure, she is making the decisions to stick to her birth plan as closely as possible. When we move into the hospital setting, it becomes less about rebozo techniques and massage and essential oils and more about advocacy, because so often we are finding ourselves in positions where we're not listened to. And where oversights are made because we're in the hands of doctors who don't look like us or care about us, or may have been taught that Black women don't feel pain in the same way, or may have just, maybe just not thought that one time it was important to wash their hands because they're not really taking the same care. They don't have the same respect for the humanity of this woman, and then, they insert a dirty catheter, and then that's what gives her the infection that takes her life, not even the birth. So there's so many different moments of kind of it's a precarious, there's so many different moments of fragility in the birthing process, and we show up to be advocates, to make sure that that her voice is heard, and to be a liaison, between the medical staff and the birthing woman, especially when there are shift changes. We're kind of her safety blanket. In the time of COVID, it's been very difficult because we've had to work remotely. So we're doing more preparation work, and depending on the state that we're in, we're not even allowed in the hospital. And so we're on FaceTime and we're texting and, just having phone calls at any time of the day or night. And so while it's not ideal, I think now more than ever, having the support of someone whose job is to protect you, especially if that person can look like you, it just provides an added layer of comfort and really increases our chances of not just survival, but thriving through this experience, and even having a good birth experience to write home about.
I just want to, we'll get into a longer discussion later, but my first two questions for you is, as an actress, how did you get involved in becoming a doula, and what type of training did you have to go through?
So I've been a doula for about 10 years, and while my main job is acting and it's very demanding, I've always managed to somehow be present at the births that I was supposed to be present at. It's pretty miraculous how that happens. And then on the ones that I am not able to physically be present at, I have created a system of support. If there are a couple pregnant women at the same time, we'll have a WhatsApp group where I'm sending resources, we're answering questions and things like that. And so even though for most people virtual support is new in the time of COVID, that's something that I've been doing for a while, just because of the nature of my work. I'm on a television show. I just can't guarantee that I can be present. I can have a backup doula, but for the most part, at least half of my moms I'm supporting virtually anyway. So that's really been interesting to see everyone kind of doing that now. And I became interested in it when my sister got pregnant and asked me to be her doula. And I was like, what's that? And so I did my research, did some training, then that I really didn't find it really helpful or supportive. And so I was doing a lot of reading on my own, just because of the organization and how surface I felt like the training was. Okay, this is a massage technique, but they weren't talking about this work in a holistic way. Until years later, I found Sumi's Touch in Oakland, California. She is a traditional Black midwife and doula. So I did her training, and then I also trained with Latham Thomas in Brooklyn, New York, of Mama Glow, another Black woman. And what I found in these settings, trainings like led by Black women, I felt more at home, and I felt that there was a reverence for where this information comes from, that it is actually very much a part of who we are, who we've been, as Black women in this country, as midwives. We delivered everybody's babies up until very recently, until it was medicalized. Wet nurses. I mean, this is what we did. And even before this coming to this hemisphere, that's also what we did. There are doctors who found the first C-sections, European doctors who were traveling to Uganda and Tanzania. Like, what are they doing? How are they cutting these women open, and they're surviving and healing? And so there's very ancient technology that was originated with us. And so tapping back into that and realizing that it's actually ancestral wisdom and that it's in our DNA. And sure, I can get a certificate if I want to, but I don't need it because my great grandmother didn't have one, and all her babies were fine. So I did train, but I'm also like a little weary of the states taking over doulaship and kind of controlling it, because it's the one place where women, I feel like birthing women have a little bit more power in terms of who they choose to support them, how comfortable they feel, you know. So it's interesting. But yes, I did 3 trainings.
Okay. We're going to go to Dr. Williams, and we're going to go to our policy person. So, Dr. Williams.
Thank you again so much, Congresswoman Kelly. Great to see you, Yaya.
Good to see you.
Dr. Williams.
Hello. First of all, I've been involved on this issue for many years, and I've never told anybody this, but when I got married, my Aunt Florence had a premonition and says that I should not become pregnant because it would kill me. Yes, and I am thin and healthy. I work out and everything. And you know what? I listened to her. And that but this was before I even knew about the issue. It wasn't even at my forefront. And then I started studying the issue, and I realized that this is something that has been going on, and it's been systemic because of everything that has been happening. I hate to be reiterative, but this is what has been happening. And I've been on the forefront of doing as much policy advocacy as what I can do through the American College of OBGYNs. I actually sit on their Congressional Affairs Committee, and what we do is we are those helpers to help not only to craft policy, but also to support those people who are in office and are actually doing the advocacy work and voting those votes that are going to make the laws that are going to help women in the long term. So that's me.
Okay, well, let me ask you a question. During this global pandemic, what can you say, since you are practicing, that you've actually seen in your practice regarding your pregnant mothers and how they're feeling during this COVID-19 pandemic?
People are scared. Everybody is afraid. And one of the big problems, especially during March, when everything was completely shut down, if you have a patient and they needed to go in for iron infusion, or they had to come in for injections that would support their pregnancy, then those things actually just came to a screeching halt. Mm-hmm. That scared not only me, it scared a lot of my patients who were newly diagnosed with pregnancy. Like, what can I possibly do during the pandemic? I had people in quarantine. And I also have another friend of mine who sees patients in low resource settings. I'm able to do telehealth visits, you know, because we all have one of these. But my friends who are working with people in low resource settings, they may not even have a phone that's going to enable you to do a video chat. Mm-hmm. They may not have Wi-Fi access that you can actually use to actually get those resources. So we found a big gap in care. And this is something that, so I was just looking through what legislation actually had been passed, like looking at the Preventing Maternal Deaths Act and things like this and these policy changes. But for me, just seeing that gap happen in front of my eyes during this pandemic really brought the point home that if we're not attaching either a monetary benefit or a monetary penalty to these places where the patients are not doing well. Well, we know we have a maternal mortality review committees. We know we have those, but do they have teeth? Can they actually make something change? Because yeah, we look at the data, we have the data. It's great that we're actually starting to get the data. Now, are these states required to gather this data? And is that data attached to either funding or conversely withholding of funds if those numbers are not at least at the average? And of course, we know our average is horrible, but at least we have to be hitting these marks, because if we don't, then nobody's they'll just gather the data and it'll be sitting on a shelf.
Well, I can tell you that because we passed legislation where they had to give the data, and the first report was pitiful. It was just a bunch of links. And so we went back to them and said, you know, you have got to do better. But one of the problems, as you guys know already, the states are not equal. Some states do a good job, some states do a poor job. From reports we receive, some states have 2 different systems that don't even talk to each other. So we have to definitely, get that straight. And the other thing is, my district is urban, suburban, and rural. I start at 53rd and Cornell in Chicago, but I go all the way south to Kankakee County. I have 1,200 farms in my district, and I've been pushing the census a lot so we don't lose money and we don't lose representation. And in some parts of my rural district, 40% of the people cannot go online to fill out the census. That means they can't do telemedicine, and that means there's no e-learning going on also. So we definitely have a lot of work to do. But let me turn it over to Dr. Jennifer and give your opening statement. And thank you for being here.
Absolutely. Most people call me Dr. B because they see my last name and they
like I just did, butchered it up.
Yeah, no, it's totally fine. Sorry about
did I lose
that.
you?
No, there I am. Hi. Thank you so much for having us, ACOG, and myself here to talk about this incredibly important issue. Special thanks to you, Representative Kelly, for continuing to bring maternal mortality to the forefront. I greatly values the opportunity to be here and receive input from this caucus and the Brain Trust. And I'm honored to be on this panel with my brilliant colleagues. Nice to meet you, Yaya and Dr. Williams. So thank you for having me here. As the premier professional membership organization for more than 60,000 OBGYNs, ACOG is acutely aware that the maternal mortality rate in this country is nothing short of a full-blown crisis. The rise in this rate are complex, many, and interconnected in a system that disproportionately impacts the health and well-being of communities of color, and in particular, Black women. Nothing short of comprehensive social, economic, and healthcare-focused efforts will be enough to reach the root of the shamefully poor maternal health outcomes in this country. We recognize that our commitment to an improved future requires an honest examination of the past and the present. Systemic and institutional racism are pervasive in our country and in our country's healthcare institutions, including the field of OBGYN. Reckoning with this history and the weight that it carries on in the present and the future is an organizational responsibility that ACOG takes very seriously. On a personal note, I'm an OBGYN with many intersecting identities. I'm a Cubana, a Latina that exists in this world as a white woman. I'm a first-generation American citizen whose parents were able to provide me stable housing, quality healthcare, and an amazing education that allowed me to have the honor of entering into the healthcare field. I'm tasked on a daily basis to confront my privileges and use my power to work to correct inequalities, particularly those impacting the communities of color where I come from. It is a bittersweet experience to work in medicine. I am humbled to offer my experiences to people during some of the most vulnerable moments of their lives, like the birth of their baby, while simultaneously getting a front row seat to the stark injustices they face as a result of the system of medicine. That's why I'm proud to represent an organization that is doing the work to grapple with medicine's dark history through collaborative and transformational relationships. Most recently, ACOG led a collective action statement addressing racism that was signed by over 20 professional organizations. The statement outlined our commitment to improving education, scholarship, policy, and clinical care, racial justice lens, and a pledge to continue to fight against persistent healthcare inequalities. ACOG as an organization is all hands on deck, shifted into high gear to address the top priority of healthcare disparities relating to women's health. ACOG has championed efforts to extend Medicaid to 12 months postpartum, worked to achieve 33 states enrolled in the Alliance for Innovation on Maternal Health, which is a national data-driven maternal safety and quality improvement initiative, and has worked at the state and federal level to ensure that every state has those maternal mortality review committees that Dr. Williams was talking about. Currently, we are working with our champions in Congress to support the passage of the bipartisan HR 4995, which is also known as the Maternal Health Quality Improvement Act, and Congresswoman Kelly's HR 4996, the Helping Moms Act. We are confident that these can get across the finish line this year and will have a meaningful positive impact on maternal health outcomes. We are also honored to support HR 6142, which is the Black Maternal Health Momnibus. We deeply value our partnership with Congresswoman Kelly, who is a true visionary and champion, and recognize the life-saving potential extending Medicaid coverage to 12 months postpartum before it became the hot topic that it is now. We look forward to continuing our collective work to end preventable maternal mortality and eliminate racial inequalities in women's healthcare. Thank you again so much for having me.
Thank you so much. And your question before we get into the wider discussion is, ACOG is on the record supporting implicit bias training for physicians. And, you know, when I heard the studies that, you know, people do better when it's someone that looks like them and relates to them. And then I heard about, you know, how they think Black women can take more pain. I'm the biggest chicken there is, you know, so when I heard, you know, things like that is just so amazing to me. And then different stories around, I remember a story, a guy, he thought he had tennis elbow and he went to see a doctor. He was Black, the doctor was white, and the doctor said, okay, you can do this, that, and the other. And the guy kept suggesting, well, aren't you gonna do this? Or aren't you gonna do that? And then finally the doctor said to the patient doctor, oh, are you in medicine or something? He said, yeah, I'm a doctor. And when he said that, that's when the treatment, you know, started changing, and, you know, there were other suggestions and things like that. And it's just so mind blowing to hear that, you know, in 2019, 2020, it's just really mind blowing. And I'm married to a doctor. And as I shared, my cousin is an OB/GYN in New Jersey, who like you ladies are connected to Brown. These are Brown ladies you're around, Dr. Williams. So, but it's just so, like, how can this training, Dr. V, be improved? And feel free to join in, ladies. But
yes, thank you for that question. I think implicit bias training is the very beginning. It's the start of a much longer, ongoing, continuing re-education of the system of medicine. As I mentioned in my remarks, the system of medicine is steeped in a racist history. Yaya mentioned that, and it is something that we recognize. So we have to start somewhere, which is by teaching everyone who goes into medicine, regardless of what your race, ethnicity, or background is, that we all have implicit biases that should not be impacting our ability to care for patients. Additionally, I think some of the things that you brought up really relate to patient-centered and patient-led care. When we are blaming patients for their not doing the right thing for their tennis elbow, regardless of whether it's physical therapy or a doctor or a nurse or whoever it is, we are not participating in patient-centered care. And so ACOG is really proud to be working with the National Birth Equity Collaborative with Dr. Joia Crear-Perry's group to really be working on patient-centered care, particularly in with communities of color, where medicine has not done a great job, frankly. And so we have a really long way to go, but the first piece is recognizing that we ourselves have work to do, and that's where that implicit bias training really comes in.
didn't know if anybody else had a comment.
Well, the story.
I know you were getting ready to say something, but also as you're answering, talk to me about doulas, because it seems like, and maybe it's just people I've met, most doulas seem to be women of color. Is that accurate? Or that's what it seems like. I might be totally wrong.
Well, I was just gonna say that I relate to the story that you told about him receiving the care that he should have received in the beginning, only when it was learned that he was also a doctor. I experience that all the time, and I think it's an interesting coincidence that I'm on a TV show where I play a nurse. And so there's a, whether someone watches the show or not, there's this sense of familiarity, there's this camaraderie, there's this trust that I'm afforded that somebody else may not be. That I'm also, just by virtue of having to read scripts and use you all's, the doctor's lingo, I'm familiar with terms that not everyone is familiar with. So if I overhear something, being ordered that wasn't on the birth plan, I know what it means. And I can go and, step in gently and say, hey, is this intervention absolutely necessary? Or, and there's this oh, right, there's this idea of she's one of us. But what about when they don't have that? What about when we're literally just human beings, when we're a doula, when we're birthing mothers? Why are we not afforded that respect, from the beginning? You know, that should not have to be earned. You should not have to consider me a club member in order to receive the care that everyone should have. So that's been something very interesting. I think I'm in a really particular point of view when it comes to that. But I actually don't experience an over, abundance of Black doulas or doulas of color. I know a lot of them because we're having conversations, we're calling each other up, asking questions, giving references. Hey, have you ever dealt with this before? A mom has a question about that, and we support each other in that way. I'm part of a couple of WhatsApp groups, and online communities. There are many of us, but I am aware that in many states in the country, it's actually the opposite, that most doulas and midwives, if anyone's interested in giving birth outside of the hospital setting, they're really hard pressed to find a midwife and or doula that who are of color.
There is a question that came up during COVID. How are women of color dealing with this new normal, and are more women of color seeking out doulas?
Yes, I know that there's been a huge increase during COVID of women seeking information, doing trainings. The training that I did a few years ago started out, I think there were maybe 20 of us. And I supported a woman recently who actually just gave birth a couple weeks ago. And she's also a doula herself. And she told me that the same training had 112 women in it. So there's definitely a rise in women seeking doulas and people feeling like this is their calling and that they want to help on one of the many levels that the problem needs to be addressed at. Were you going to say something?
And I just wanted to add that I've found that a lot of my patients who I'm their physician have been very interested in having doulas. And I know personally in my practice, I welcome doula support because when I'm on the labor floor, I'm taking care of potentially, 10 to 15 patients at a time. And so I can't be in the room all the time. And so to be able to have someone who has followed them through their pregnancy and be there supporting them is incredibly valuable. I was trained by midwives at Brown, snaps again for Brown. And so I really love the collaborative nature of having multiple birth providers being able to support people during the experience in the hospital.
Dr. Williams and Dr. V, are men OB-GYNs as welcoming to doulas as you guys are?
I actually do work with a male OB-GYN, and he's an African-American guy, so I think he's a lot more in tune, of course, with the implicit bias that can come with being African-American. So he is a lot more in tune with it. Now, some of the older men, and I'll have to say this, this is what it is. Some of the older men under whom I trained really frown upon the use of mid-levels and the use of doulas during the birthing process and during the prenatal care process because, they kind of have a little bit of, this is my thing, I know best, but that's a patriarchal mentality. But the good thing is, and they've actually done a study about this, women doctors do tend to be more empathetic. But what is incumbent upon us to do right now, especially when we're bringing new physicians up, and through like the ACGME, they're actually recognized, and that's the American Council on Graduate Medical Education, really long, by the way, is to include bias and implicit bias training, not only, yes, at the graduate level, that's where I'm talking about, that's what I know about, but it actually needs to be extrapolated backward to the medical student level so that men and women are receiving that training from the very beginning, like the first day of medical school, all the way through their last day of residency training, And it should also be part of recertification. When you're doing, we have to do board recertification every year. Why is that not part of our recertification? These are things that we can do systemically that I think are going to help. And back to your answer, yes, my guy's good, but older generations, younger generations are starting to kind of understand how important it is.
Yeah, I think emphasizing the training piece and making sure that instead of looking at people by gender or how they identify in their gender, really focusing on training our trainees, both residents, medical students, and even undergraduates, about patient-centered care, patient-led care, and empathy and compassion. You know, for me personally, I've had really, you know, my first gynecologist, my first personal gynecologist was an older man, and it was fantastic. He was one of the first people that ever talked to me about sex openly. I grew up in a Catholic household, and so that was a good experience for me to have. And some of my best teachers have been men, and so I think that it's definitely possible to have excellent male gynecologists, and it's incumbent upon us, those of us who are teaching the next generation of healthcare providers, to ensure that no matter what their gender is, they are compassionate, empathetic, and patient-centered.
Okay.
Congresswoman, just let me interrupt for a second. We have questions in the chat room. Do you want me to read them, or do you want to?
I see another one about, I'd love to hear if there are policy changes that have been made during COVID to improve maternal health, telehealth flexibility, for example, that we should continue moving forward. So if you guys don't answer that, I'll answer because I want to see it move forward, but go on.
Oh, I have to unmute myself in order to actually speak to that. I do know, because I'm in private practice, and so I had known since April, if I'm not mistaken, they have been reimbursing. So a lot of physicians weren't doing telemedicine because we could spend 20 minutes just like what we're doing right now on a video chat, going over everything, and we weren't getting reimbursed for that, or it would be very difficult for us to get reimbursed for that. But now, actually, I think all of the major carriers, I know the ones I work with, Blue Cross, United, Cigna, and Aetna, all are actually now reimbursing for telehealth visits. And I have a feeling, since we do have some patients, we're all patients right now too as well, tell your insurance provider, hey, you know what? I really appreciate being able to do a phone call with my doctor or do a video chat with my physician. I want you to keep that going. You, Representative Kelly, as a legislator, can encourage, but it's really going to have to be at the patient level, because when patients are advocating for themselves, they, hey, you know what? I don't want to have to drive 35 minutes to have a conversation or to go over results that I might be able to do more efficiently on the phone or on video.
And actually there's, you know, I have legislation and other people have legislation too. Our legislation evaluates what has happened because we think that telemedicine can be the great equalizer because, you know, we deal with the social determinants of health, and Black and brown folks and Native folks are on the short end of, you know, healthcare access. Yaya, did you want to say something? I didn't know if you were.
Congresswoman, there are also questions in the question and answer. Mia Keys asks, hi, Dr. Nicole, can you talk more about why Black babies who are cared for by Black doctors have better health outcomes?
Oh, well, Mia Keys, of course, knows this. And I think we kind of addressed it ever so slightly previously, but it's more of a factor of empathy and coming from a common ground and having common experiences. Look, we've all experienced microaggressions. Everybody knows about that now. Thank goodness to people like Representative Kelly and other like-minded legislators that things like this are actually coming to the forefront. But what we know is that when Black people take care of Black people, those people do tend to have better outcomes because we know what it's like. And unfortunately, if you haven't walked a mile in my shoes, I mean, yes, white doctors can be incredibly empathetic, and it is something that we need to work with them, kind of to be to help us along, but we need to help ourselves. And that's one of the wonderful reasons why when we get more Black doctors coming through the pipeline, then we are going to experience those better outcomes because we've all been through it. there were only 2 Black people in my med school class. And this is the late 90s. This is not like it's 1967 or anything like that. And only 2 Black doctors were made from Loyola University that year when I graduated. That's a shame. We need more. And if we cannot get more Black doctors, we need to get more Black mid-levels. If they're going to kind of keep us from the gates of medical school, then we need to find a way around that.
And Yaya, I was going to ask you, do you see more interest in people being doulas? As we're saying, we need more, especially more women of color.
Yeah, I do. You know, I recently had a case where, and it's not just doulas, but the care providers as well. I've noticed more women of color voicing concerns and fears about becoming a statistic, and because of COVID and the focus being on COVID cases in most hospitals, a lot of women have felt that it's just safer to birth at home. So there's also been a greater number of home births. And that, starts a whole list of questions and fears, because these are women who would not have traditionally opted for that option. So there's a lot of education that goes into it. And there are midwives who are being sought out. And what I have found really disheartening is that even when a woman is aware of the risks and is deciding, okay, I'm having a baby during the time of COVID, what can I do to protect myself? Well, let me try this other option. They're finding that the hospital is being brought into their homes, because a lot of the midwives are being trained in the same way. A lot of the midwives have the same implicit bias that doctors do. And I'm not, here to, we have so many wonderful doctors, and I love hearing the perspective of the doctors here on the panel. But as we all know, there are so many out there who just are not as sensitive and who are not trained in the best ways. And so when you have the midwives kind of doing the same thing and not trusting women and forcing them to, do some kind of premature induction, or, just not taking their word for it, it's a very spiritual time, and I think women, even if they didn't have strong intuition before, when they're pregnant and in approaching labor, there's just information that comes to them, and they don't often even know how they know something, but they know it, and so there's an added element there too. It's yes, listen to us in general, but especially listen to us when we're about to have a baby, because it is a portal between two worlds, and there's clarity there. And so this recent case that I had was a midwife who really made this woman break down, abandon her care, and she had to find another midwife at the last minute just to feel supported. And she almost gave up and was literally on the phone looking for a new midwife, crying and saying, I just want to live. So people are very hyper aware of what's going on. And I really, really hope that this is encouraging anybody that is, wanting to be a midwife especially, and a doulas as well, to go to train, go to medical school, follow that inclination, that whisper, if it's your calling, we need you. Because even having a doula of color, doulas can only do so much, and a lot of times we feel helpless because we are not we're kind of medical professionals, but we're not at the level, and ultimately we're just there for the moms. We can't speak for them, in the hospital. Sometimes we can, speak have them speak through us, but it's a very delicate balance, and we have to be also liked and respected in the hospital setting. If the doctors are feeling like we're a liability or like we're somebody's in their way, that's not going to help the birthing woman. You know, so there's a very delicate balance that needs to be kept in the room. So yes, there are more doulas of color in training, but we need more Black midwives.
Okay.
And doctors.
Now, unfortunately, our time is coming to an end. But one thing that I hopefully will help, that Mayor Bloomberg gave all that money to the 4 medical schools to try to help the diversity pipeline, because that's what we hear over and over. We do need more doctors of color. But for those who are watching on Facebook today, and many will be considering pregnancy, and I have, my husband and I have 4 kids between us. 1 has had a baby, 2 of the women have not yet. But what can they be doing ahead of time to ensure a health and safe pregnancy and delivery? What would you recommend, starting with Dr. V?
Thank you for that question. I think that what folks do if they're considering pregnancy is, depending on what they're comfortable with, I would have them reach out to their current healthcare provider, whether it's a midwife or a physician, and ask them if there's any preparation that they need to do. There is some preconception counseling that we usually recommend for folks, just to make sure that if they are in a position in which they can plan a pregnancy, which is not always the case, and that's totally okay, but if you are in that position where you're able to plan ahead, there's some blood tests that we can run to screen for antibodies and make sure sort of all of that's on track, get you started on a prenatal vitamin so that the developing baby will be get all the vitamins that that baby needs, and then also be able to start right from the beginning, even before you are pregnant, with thinking about how you want your pregnancy and your birth to go, and really getting close to your providers. So that's definitely something that I would recommend folks doing if they have the opportunity to. But that doesn't mean that if you get pregnant without having done those things that you did something wrong. That's okay. We want to see you whenever you're comfortable coming in, and we welcome you at any point in your pregnancy, and we'll help you try to keep that as healthy as possible.
Dr. Williams?
Thank you.
Since you might be delivering someone I know.
So when it comes to preparation, I start with basics: diet. You're not smoking, avoiding any illegal, any substances, of course, and track the weight, because I always tell my patients, we want you to gain around 20 to 25 pounds during the pregnancy. And when my patients are also affected by obesity, we know that that can also lead to adverse birth outcomes. So I talk with my patients all the time, because we do a lot of pregnancy planning in our practice, about eating clean, making sure that you're avoiding overly processed foods. Of course, we don't have a direct link between, salty foods and high blood pressure. It's a bit of a myth. However, when it comes to just overall comfort in your pregnancy, when you're eating better, you're going to start feeling better. So that's where I start. Then I also go with prenatal vitamins, and then I also offer genetic testing. So there are 3 things. We go diet, we go prenatal vitamins, and genetic testing.
Someone did ask about do things like hypertension and diabetes and pre-diabetes contribute to high mortality rates. But I know from all the research that I've done also that the feeling is that so many of the statistics that really that many women should not be dying regardless. So I don't know if you want to comment on that real quick.
Yes, regardless of whether or not that patient is obese and has high blood pressure and diabetes, she is still entitled to the proper care. And we know we have science that can help us to help these women have better babies and better outcomes. So yes, you're absolutely right. Just being obese and having high blood pressure, yes, these are risk factors for adverse outcomes, but they do not have to equate to adverse outcomes. It's at that implicit bias. We always keep going back to that, but it's the implicit bias that we ignore these soft signs that something's going on with the pregnancy until it's too late.
Okay. Yaya, anything else?
Yes, I will add to all of those physical preparation things a mental, emotional aspect of it. And so, as a doula, I encourage women to start really just tuning in to their bodies. I think, meditation, as early as they can start practicing that, is very, very helpful. Being able to take charge of what's going on in their minds. All of our lives, we've heard horrible birth stories from our mothers and aunties and grandmothers. And what I've noticed is that when we rewire our brains and when we replace those stories with positive ones, we can believe more easily that we can have a positive outcome too. And so you can start by reading some books by Ina May Gaskin. There are some documentaries out there. There's one called Orgasmic Birth that takes it to the other extreme. It can actually not be painful, but be pleasurable. But even just expanding your mind and, having a more authentic experience with what you're feeling is very helpful, because when you eliminate fear from the process, there just are better outcomes. With every contraction or wave, if you're looking forward to it as an opportunity to meet your baby, instead of, oh my God, this is what I heard about, this is the worst pain of my life, births can happen a lot more quickly and easefully. And the other thing I would say is dance. I know I'm speaking for all the earthy, crunchy hippies, but really meditation, dance, belly dance, wine, open those hips as much as possible, and it really makes a difference.
Well, thank you guys so much. We so appreciate you. And people are sad that we're ending, so I'm going to bring all of you back at another time when it's convenient for you, because, COVID is not going away, and hopefully it'll be sooner than later and there will be a vaccine. But even after there is a vaccine, we still have to deal with the aftermath. So I would love to have you ladies back on sometime in the next couple of months. So thank you so much again. Appreciate each and every one of you. April, I hope to be seeing you on Chicago Med soon.
November 11th.
I watch it every Wednesday, trust me. So we miss you.
So much. Thank you so much for having me, and thank you for the support. We'll be back in
You're
November.
welcome.
Thanks, everybody.
Bye, Dr. Nicole. Dr. V, take care.
All right, bye-bye.
Bye.
Thank you.